It is great to be here. This is the September 2022 CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We are here to go through every clinically relevant article here in the CFP Journal. If you are a Canadian practicing family physician or if you're studying for the CCFP exam or both, we have got what you need to know, the clinically relevant tips, tricks, and pearls from CFP September 2022. So I see you're already halfway done.
I don't know. Most importantly, cover rating.
Cover rating. I know it's a bit of an odd one, a bit blurry here. I guess that's an artistic effect. I wouldn't understand that.
I'm giving it a 4, no more.
4. They got a stack of CFP journals and the world on top of it with a clock.
Time is ticking for the exam. Should we dive in?
Let's dive right in. So what is the first article we want to take a look at here? It's about cardiovascular disease.
Cardiovascular disease, and what about it specifically? Investigations and some of the risk markers. Now, I'm not going to dive deep into that, like lipoprotein A, troponin. The real meat of this article is about when to start statins.
Yeah, so there's several indications when statins are going to be reasonable to start. And so if you know your patient has atherosclerotic cardiovascular disease, then you know straight up statins are indicated.
So that's the first one. Next, we're going to talk AAA, greater than 3 centimeters, or any sort of aortic surgery that they've had. Boom, they're on statins. What else?
Exactly. People with diabetes, people with chronic kidney disease, statins are going to help reduce their risk of having a CVD event.
Chronic kidney disease is another indication.
I think I just said chronic kidney disease, but it is that important that we should say it twice.
Say it twice, because you got 2 kidneys.
Yeah.
You have to have it in both.
And if you got an elevated LDL, so the guideline says if it's greater than 5, that's when you want to start a statin.
And then high Framingham risk scores, that's another one. So that's like 5 different things that you might have to write down on a SAMP.
You hear the next article is about what? Ear piercing?
Ear piercing.
If you've got a left field SUE, this SUE comes out of nowhere, or a SAMP question, you're like, what are they talking about? Ear piercings? What are the complications? It's a totally reasonable SAMP question because it was in the September CFP journal. So what are the complications of ear piercings?
So the first one was wild, and now I still have my ears pierced from med school, but embedded earrings, so they can get embedded and stuck in there is the first one. I wouldn't have thought of that if I didn't read it in the journal.
If they've got ear piercings, they can end up with keloids and hypertrophic scarring.
Next, a nickel allergy or an allergy to the metal contained in the earrings. If you've got someone who's come in, has a new piercing or new contact, a contact allergy.
And finally, auricular perichondritis, very serious disease. It can be destructive to the cartilage in the ear. You want to know your bugs, especially for any microbacterial illness. What are the bugs that cause perichondritis around the ear? You're thinking about Pseudomonas. You want to cover those with your floxacins.
Floxacins, I love that.
That's the actual class.
Cover your ear in floxacins.
Cover the ears
with
floxacins with your fluoroquinolones. What is the next article about, Paul?
It's rapid recommendations. So this is part 1 of 2.
Wow,
it's too much. So additional therapy. And this comes back to that first topic that we talked about in this podcast. So what is your next line? What other drugs can you give? Now, not great evidence in this field, but is this something that you could be asked on the CCFP exam? Sure. So what else could it be? Ezetimibe or proprotein convertase subtilising kexin type 9, PSK9 inhibitors. Remember, you can use acronyms as long as they're commonly used and known across the country. So PSK9 inhibitors and ezetimibe. Commonly used in clinical practice, not necessarily, not really great evidence, but what's your next line after statins? What do you need to know? Those are the 2.
All right, so the next rapid recommendation is from a guideline from the CCS, the Canadian Cardiovascular Society. You got your patient with AFib, and they're on an anticoagulant and antiplatelet. There's another drug you should automatically think of prescribing. So what is that medication? That is a PPI.
Brilliant. Next, HFrEF. Heart failure with R, reduced ejection fraction. There's a bit of a word salad, a lot of letters. It's like teaching an alphabet to a kindergartner. What are the drugs that you need to remember for these patients?
It's amazing because this is so different than it was even just a couple of years ago. If you have not looked at heart failure guidelines recently, brush up on these. Your patients who are diagnosed with heart failure should be leaving your office with 4 medications. So what are those?
So beta blockers. What else?
Yes.
You want me to? Beta blockers, SGL2 inhibitors, mineralocorticoid receptor antagonists, and then either an ARNI, ARB, or an ACE.
Notice that a diuretic is not part of that standard therapy. So that's one of the major changes there. Moving on to asthma.
Asthma, well-controlled asthma, patients who experience daytime symptoms 2 or fewer days per week, or need 2 or fewer reliever doses per week. And what about those that, are at high risk for exacerbation, Simon?
Yeah, those are the people who should be getting an inhaled corticosteroid, an ICS. If you're high risk for asthma exacerbations, think about prescribing those inhaled steroids.
This next one is quick and dirty, but it's challenging to implement. And I think a lot of people have an emotional reaction to treating diverticulitis with
Antibiotics.
No.
Antibiotics.
No.
Always use
No,
antibiotics.
no,
you can tell me
no.
that everything I learned in medical school is wrong?
Treated without antibiotics. And this one, I still find this one challenging. I've tried it a few times, but you can just give some anti-inflammatories. Now, these are these early cases, and you get into this weird clinical conundrum where you're like, do I image them first before I decide to or not? But you can treat diverticulitis without antibiotics. We talk about game changers all the time, but I think this is one that could potentially be a game changer going forward.
Yeah, these patients used to be admitted. They used to be getting high-dose IV antibiotics, and then it was oral, and now we're saying no antibiotics is reasonable. Now, when it comes to sinusitis, we know our patients are begging us for the antibiotics. We used to give 10 days of amoxicillin. What do the new guidelines say for that?
Let's bring that down 5 to 7 days. 5 to 7 days for acute bacterial rhinosinusitis.
Let's change gears. We're going to move on to an article on concussions from the September 2022 CFP Journal. What do they have to say about concussions?
Well, I catched a little mistake here. So this is interesting. So we know that CATCH2, we teach it at the review course. It's the latest evidence. So CATCH2 is our kind of latest validated rule to figure out, do we need to image kids? We've had a big knock on the head. So CATCH2 added in greater than or equal to 4 episodes. Episodes is key here, episodes of vomiting. The article here talks about using CATCH. We want to be using CATCH2, the latest evidence and our latest tool, to be able to tell us, do we need to image these kids inappropriately or appropriately with CTs for head injuries?
CATCH2, what are you going to do? You're going to move on to the next article on seasonal allergies, patients who have allergic rhinosinusitis. So immediately, 2 classes of medication should come to mind: antihistamines and inhaled or spray steroids, intranasal corticosteroids. So let's start with the antihistamines. What do they say about that?
So this is interesting, 10 to 30% improvement in symptoms. I was like, okay, sure, allergic rhinosinusitis probably dries things up, but what gives something a little bit better? What's our next step?
Yeah, so more patients achieve control of their symptoms if you give them an inhaled corticosteroid, an intranasal corticosteroid. These are the nasal sprays, the steroid sprays. Warn your patients. These can lead to headache, they can lead to nosebleeds in about 10% of people. But compared to the antihistamines, they do a better job. You get 80% improvement with the steroids compared to only 60% improvement with the antihistamines.
There you have it. An amazing month, lots of content. We look forward to you guys listening and watching next month. But what's this? That's not a CFP journal.
This is not a CFP journal. This is one of our craziest ideas we've ever come up with. This is a study tool. And now I know what you're saying. You're thinking, this looks like a children's book, right? No, this is a study tool for the CFP exam.
It's a study tool secretly camouflaged as a children's book.
So in the back, you'll see every single page has got multiple exam tricks, tips, and habits. One of my favorite examples in here, let's flip to that page with the child who's got a cast on his leg. And you look at this kid and you're like, oh my gosh, this kid is preambulatory. He's not walking. Why does he have a cast on his leg? You got to think about
child abuse,
non-accidental injury. So the entire book is filled with little pearls like that you need to know for your exam, but it looks like a children's book. So you can actually study for the CCFP exam while reading bedtime stories to the little ones in your life.
Spend time with your kids and study. There's nothing better.
Fantastic. Thank you so much for joining us for CFP Distilled September 2022. We'll see you next month with October 2022.
See you then.